So, good morning, and thank you for the invitation to participate in this conference. I will be talking about the genetic prevalence of BRCA1 and 2 mutations in breast and ovarian cancer. I first want to acknowledge and share with you that ovarian cancer genetic susceptibility is quite heterogeneous. As you know from genetic studies performed in ovarian cancer patients, the mutation rate in specific monogenic genes might be as high as 24%, and mostly driven by BRCA1 or 2 gene mutations. But there is also a bunch of other genes that can be mutated and related with a genetic susceptibility to ovarian cancer, and we will talk about that. In addition, low-risk alleles that might not be pathologic by themselves, but a combination of these low-risk alleles may also explain an important fraction of ovarian cancer susceptibility, and this will be quite personal and different among different members of the same family. What do we know in terms of histology and ovarian cancer? That most of the high-grade serous or endometrial cancers are related. Those that are related with the gene mutation are related with BRCA1 and 2. But also those that might have a transitional histology or a clear cell histology might also be related with BRCA1 and 2. Mismatch repair gene mutations, those that confer risk for Lynch syndrome, might be related with endometrial, both high-grade and low-grade, and these are the third group of gene mutations. And finally, most importantly, that the rate of BRCA1 and 2 mutations in patients with ovarian cancer and a mucinous histology is almost in all series 0. And the fact that finding a mutation might not be necessary that is causing that tumor, but just that this is the prevalence of mutations in even the overall population. And what's the importance? How much there is an increased risk of ovarian cancer when a woman is a mutation carrier in any of these genes? And the data comes from different case control studies, and these need to be very well matched and as large as possible because the prevalence of mutations in these genes in the population is very low. And I've tried to summarize from the review by Susan Domchak and Mike Robson the evidence that we have in terms of increased risk of ovarian cancer when a woman is a mutation carrier in BRCA1. And as you can see, there is a relative risk increase between 3 and 5, depending on the control population. This is sporadic, and this is familial cases, controls from familial cases. And you can see that the risk may actually increase quite a lot if it comes from a sporadic compared to familial cases. And then RAD51C and D are the other genes that have consistently shown an association with an increased risk of ovarian cancer, with relative risk ranging around 5 or even 12 compared to the non-carriers. And how does this translate into absolute risk? Because there are some studies, modeling studies, that already confirm and show that prophylactic oophorectomy is saves lives and is cost-effective when there is at least a 5% lifetime risk of developing ovarian cancer. And as you can see here, for BRCA1 and 2, the evidence for association with ovarian cancer is very strong, and the absolute risk, lifetime risk, is above 10%. This also holds true for BRCA1, for the mismatch repair genes, and finally for RAD51C and D. So probably, if we were to consider germline genetic testing for ovarian cancer susceptibility, at some point we should incorporate all these genes to rule out a genetic predisposition to ovarian cancer. But do not forget that also somatic BRCA1 and 2 mutations in ovarian cancer patients is quite common. The prevalence is between 6–7%. So if you were to start tumor genetic sequencing and you find a mutation in an ovarian cancer sample, consider to reflex to germline, but also consider that this might be a somatic mutation and it has therapeutic options. What about breast cancer genetic susceptibility? This is even more complex than for ovarian cancer. It is very heterogeneous, and there's still a high proportion of breast cancer familial aggregation that still holds unexplained. And you can see that the most frequent genes that are mutated for breast cancer are BRCA1 and 2 with a very high risk of developing breast cancer. But also there are moderate genes such as PALB2, CHEK2, and ATM, and others that also confer a very high risk but are very uncommon, such as TP53, CDH1, STK11, and PTEN. And then, at this time, there are at least more than 300 low-risk alleles that in combination confer the polygenic risk score, and that any of us can be carrying a combination of any of these genes. And for those that are in the highest percentile, the 10% percentile, there is at least 3 times higher risk of developing breast cancer compared to those that are in the lowest percentile. So these might work as a common genetic susceptibility to breast cancer, but they also can confer a modification of the risk that is already provided by being a mutation carrier in BRCA1 or 2 or other moderate penetrance cancer genes. What is the frequency of germline pathogenic variants? That depends on the cohort that we are studying. So if we go to the general population, average population from Western countries, it is expected that approximately 1 out of 300 people might carry a pathogenic variant in a BRCA1 or 2 gene. This increases to 2.5% if we go into the Ashkenazi Jewish population, where there are 3 founder mutations, so that makes genetic testing even easier, and there is population screening programs already in place in Israel and also some other countries. But then if we move into the breast cancer population, if we were to test all unselected breast cancer patients, the proportion of them who would be mutation carriers in BRCA1 and 2 would not be higher than 5% and more close to 2 to 3%. And then we have some personal and family criteria that may increase the threshold to above 10%, such as triple-negative breast cancer, such as a young age at diagnosis, before age 40 or 45, bilateral breast cancer at a young age, breast and ovarian cancer, and then breast cancer plus a family history in first or second-degree relatives of young-onset breast cancer, ovarian cancer, pancreatic cancer, or prostate cancer with a high Gleason. And these have been the criteria that most of us have been using for cancer risk assessment and to test for BRCA1 and 2 mutations. As you can see in this series from Boston, from 500 cases of unselected breast cancer patients, the overall prevalence was 6%. This was enriched by Jewish mutations population. And as you can see, the prevalence of mutations decreased with the age at diagnosis, being as high as 12% before age 46 and only 2% above among those that were older than 60 years. What about pathology? There is this clear correlation between triple-negative breast cancer and a mutation in the BRCA1 and 2, as you can see here. And then it is less likely to find mutations in BRCA1 and 2 among patients who harbor a cancer which is HER2 positive. It is not completely impossible, but the prevalence goes much lower. And among the ER positive, HER2 negative, around 5%. As you can see here, this is also a series from Germany. The prevalence of BRCA1 and 2 was 16%, mostly in BRCA1 than in BRCA2. And if you incorporate age in this equation, then the proportion also changes. So younger age and triple negative increases your likelihood of finding a BRCA mutation. And this is also another series, an international one. And you can see that in the absence of family history, a triple-negative breast cancer older than 60 has a very low risk or a low prevalence of BRCA mutations, but this is much higher with younger ages at diagnosis. So finally, just as a wrap-up in terms of histology, tumors in BRCA1 and 2 mutation carriers are mostly invasive ductal carcinoma. They are unlikely to be HER2 positive. They tend to be grade 3, sometimes grade 2. And also remember that somatic mutations in BRCA1 and 2 may also happen. This is approximately estimated in a proportion of 2% for each gene, for each of these genes. And if you're doing tumor sequencing, remember to reflex to germline, but also consider the possibility of having a somatic mutation. So why do we need all this, and what are the reasons to undergo genetic testing? First, and that's where we started 20 years ago, to estimate cancer risk, being able to identify individuals at sufficient risk that can be considered for enhanced screening and early detection options, and this has already been addressed by Dr. Singer. For early detection, specific risk surveillance options, risk reduction options, even chemoprevention options that you know have now in place, such as RANK ligand inhibitors, and finally targeted therapy. For those that have already developed breast or ovarian cancer, the vulnerability caused by BRCA germline mutations and somatic mutations causes homologous recombination repair deficiency and allows to identify those tumors that might be more sensitive to platinum agents, DNA damaging agents, and also PARP inhibitors. And this has increased the interest in testing for these individuals and to do it in a much faster turnaround time. So this raises the questions on who and how to test for BRCA1 and 2 gene mutations. And I have put it 3 different scenarios. One is in patients with early breast cancer, and we know that most of our patients are diagnosed in this earlier stage. I think this is a very good opportunity to try to test for BRCA mutations here. We can here talk about different options in terms of management for them, neoadjuvant therapy, type of surgery, not for the breast conservative surgery, but the need of, or the option of having prophylactic contralateral mastectomy, and it allows to promote other surveillance and prevention for other tumors, such as ovarian cancer, and also promote cascade testing in relatives. In metastatic breast cancer, I would still enhance the importance of performing germline testing if it has not been done before and according to the guidelines that you might have in your countries. But also remember that if you are doing a biopsy of that metastatic because you need to assess the hormone receptor and the HER2 status, is also a good opportunity of having that tumor sample and then doing tumor sequencing there if you're going to test for PI3K or HER2 mutations or AKT or SER, and then having BRCA tumor testing there as well. And if a mutation is being found, then reflex to the germline. And finally, there are now schools of thought promoting testing for all invasive breast cancer and high-grade DCIS. And this will definitely require a new genetic counseling framework, a multidisciplinary approach in which GYNs or medical oncologists are doing mainstream genetic testing, and this will require to keep with the quality of doing genetic counseling and having a very close relationship with clinical genetics. In this scenario, one also may think whether not only BRCA1 and 2, but also PALB2 mutations can be incorporated, and what about other genes, and what will be the cost effectiveness of all these approaches. And we will talk about this. Because do we have challenges and barriers at the time of undergoing genetic testing? Why has not this been implemented so quickly? And I'm just going to address some of the clinical barriers that I think we are all facing. And one of them is the genetic counseling pre and post. We know that this is a germline susceptibility, so this is not a conventional biomarker, and there are implications beyond the patient, especially around the family, her first-degree relatives, and all the explanations are time-consuming for our busy clinics. This also requires communication skills, not to make our patients more anxious, but to see the benefits and opportunities of preventing breast ovarian or ovarian cancer by doing cascade germline testing in her family members. And there are legal requirements in all different countries that all need to be addressed, and consent forms need to be signed. It is important to insist in the importance of the duty to warn. We must inform our patients if a mutation is being identified to tell their family members that the mutation is running in the family and that there is the opportunity to undergo cascade testing. But we cannot contact our family members in most of our countries. What genetic testing should we be doing? BRCA1 and 2, and do it as much as possible, or should we incorporate panel testing? Technology has arrived into our clinics. For the same price, we can test for more genes, but the rate of variants of unknown significance increase. How do we have to handle all this? And these are some of the challenges that we are now facing. And finally, the cost and whether to start with tumor or germline first. So what models do we have now in place? One is doing the traditional genetic counseling, which is referring the patient to a cancer genetics clinics. It is probably more slowly, but it's cautious and it's an established method. And then we have incorporating germline genetic testing into our clinics, either through the treating clinician or through nurses or genetic counselors. And the importance about this is that if we do it, it will be faster, but there is the question of whether it will hamper the genetic counseling process. And we have the UK and the Scotland models as one of the ones that have been implemented more rigorously in our setting. And for both breast and ovarian cancer, they have developed a model in which the gynecologist or the medical oncologist is the one who's performing pre-test genetic counseling and ordering the genetic test for BRCA1 and 2. And then, depending on the results, then the patient is being referred to the genetics team. And we have some experience already published in JAMA, now this year, in breast cancer. And they selected patients for BRCA germline mutation based on personal criteria, such as ovarian cancer, breast cancer at a young age, triple-negative breast cancer, 2 primary breast cancer or male breast cancer. And they, with performing genetic testing of BRCA1 and 2 in these patients, the prevalence of finding a mutation was 10%. And 50% of these carriers would have been missed if traditional family history would have been followed. And cascade testing was very effective. There was satisfaction by both the patients and the healthcare providers. And there was also a cost-effective analysis, around £20,000 per qualis in this approach. We do have also some cost-effectiveness analysis in ovarian cancer, also coming from the UK, with a threshold of also £20,000 per quality of life year, and then incorporating also Palbitu in breast cancer patients. So as you are saying now, cost-effectiveness is now coming into our scenario, which is probably a good thing because we are putting money in place, meaning that already we know that these might be effective and beneficial options for our patients. And this is the one that probably has struck me more than anyone else because it's performing panel testing in a population-based women older than 30 years of age, according to the payers and the assumptions in the UK. And after doing a cost-effectiveness, different estimations and analysis, at a threshold of £30,000 per quali, the strategy that was most cost-effective in 82% of the cases was performing panel testing for breast cancer and ovarian cancer genes in women older than 30 years. And this would allow a prevention of 2% of breast cancers in the UK and 3% of ovarian cancers in the UK. So I think it is worth to read this paper and analyze the assumptions, the benefits that they are estimating from performing prophylactic oophorectomy and prophylactic mastectomy, the uptake, and thinking about whether this might be an option that we might be going. So my take-home messages to finalize is that genetic testing for BRCA1 and 2, in my opinion, should be standard clinical practice for patients with ovarian cancer. And we must think about considering multi-gene panel testing in this population as well. Selection of breast cancer patients for BRCA1 and 2 and Palbitu genetic testing can be based on the threshold probability in your country and actionability, and this should also reasonably be implemented. Multidisciplinary approaches will be really important, and they need to work close to mainstream oncology clinics and GYN clinics to provide an adequate genetic counseling and testing. We cannot hamper quality because of quantity. I would incorporate new genes as long as their clinical validity, meaning estimation of cancer risk, and actionability are proven so that we can do something if a mutation is being identified. And by doing this, we improve our health outcomes in our patients. And finally, cost-effectiveness analysis will help to promote implementation in the national public health systems where we are working, and I also encourage you all to perform this analysis to finally do it. So thank you very much. I would recommend to keep calm and keep doing genetic testing, and thanks for your attention.